a day, I live in a dream. I live in a dream.
Welcome to Only Try to Help, the podcast where we try to help you be helpful to other people. My name is Kate Watson, and I am here with a friend of mine from way back. I'm here with Andrea. Andrea and I worked together at an inpatient psychiatric hospital when I lived in Baltimore, and we were there together. So shout out to Shepherd Pratt, that where we met, where our friendship began, and I'm so glad that we're reconnecting now because I'd love for you to tell us a little bit about the work that you're doing. I think that it could help a lot of our listeners, but why don't you first just tell us a little bit about you?
Okay. Well, let's see. I've been a nurse now for 30 plus years, 30 years, and been doing psychiatric nursing for 20 out of my 30. So I kind of fumbled my way into psychiatric nursing. Never thought I'd be working in psych, but here I am, and now I can't imagine doing absolutely anything else. It's definitely turned out to be my calling, which I had no idea would be. But I currently work in an emergency department in a hospital in the Baltimore area. Um, where I work is what they call the psychiatric emergency services or psychiatric evaluation services. And so it's a little locked area of the emergency department for psychiatric evaluations.
Yeah. So you're calling this your calling. What do you love about it, Andrea?
Let's see. I think over the years I've done a lot of actually precepting and teaching other people. And I think what I've kind of narrowed things down to is that I think psychiatric nursing, well, I'll speak for nursing, psychiatry in general, but I'll speak for psychiatric nursing. It's definitely an art. It's not so much of a skill set that you can say, here's XYZ, this is what's showing up, and this is your standard protocol of procedures. It's not like that. Um, I think what I enjoy about it is that everybody is an individual and you get to really appreciate that. So you never know what you're going to get. Um, and that is something I really enjoy. Like I said, you never know what you're going to get. Some of this stuff, I mean, you can't even make some of this stuff up. Like you, there is stuff, you think you've seen it all, heard it all. Nope, nope. There's something else right around the corner. So that's actually part of the enjoyment. Um, and, you know, there's obviously a lot of sad, sad stories. And there's some really, really sick patients, like psychiatrically ill. And, it can be very stressful, but there's a lot of good, um, being able to see people get better, even in my part of the emergency department. It's supposed to be short term, but we do have people there sometimes for several days while we try and find them an inpatient bed. And even during that time, you can see people improve. So that's very rewarding. And people like, I don't know, so many situations where you end up in a hospital or something along that line. People are at their lowest point in a lot of situations. And just to be able to be there and offer some kind of comfort or some advice, but I don't offer so much advice as I do more listening and kind of processing. So it's not like I sit there and, tell you what you need to do because nobody wants to hear all that when you're in the middle of a crisis. So,
Not at all.
so that's
I
why I
think this
like
is
it.
Yeah, I think this is helpful. I mean, a couple things stand out. You're talking about how it's never the same. So in that regard, there's always something to learn. There's always like something to keep you to keep your brain active and engaged. But you've also mentioned how there's a lot of nuance to it that every person who comes in is different,
Right.
and that really requires that you bring yourself to the work. That the art you've mentioned is like you bringing your own personality and your own heart and something about you. It's not all a science. There's something artistic about this that you're bringing to the table, and I think that's really cool.
Yeah. And I think that's what's great about where I work is that there's so many we all as staff come from so many different experiences. So it's like whatever kind of like whatever demographic of situation or patient that's coming in, there's bound to be somebody there that can step in and would be more appropriate in some capacity, or situation, or just, they can just get a better rapport, I guess, to better way to say it.
Remember that from when you and I worked together, and of course this was like 15, 20 years ago, but I remember being at the inpatient psychiatric hospital and different patients would come in and the staff would kind of look at each other and be like, well, you're good in those kinds
Yes,
of cases. So like, Kate, this patient is the kind of patient I think you would be good at working with, and whatever
absolutely.
reason that may have been. And yeah, and then there would be times where I would look at another staff person and say, this particular patient would be a great match for you, maybe not such a great match for me. And so that's the team environment that I think is
Yes.
cool.
Yes, very much. And that's very much how we roll at work too. Like, obviously I spent almost 10 years working with the adolescent girls. So that's a tough population, as anybody who has teenage girls at home. And worked with teenage girls. So, but I loved them. I loved working with them. So when we have the young ones come in to work, everybody's like, Andrea, yep, that's yours. Take that one under your wing. I'm like, I got it. I got it. So,
Yeah.
and then I specifically very much know what kind of patient I do not do well with. So, I will just look at my coworker and she's like, yep, got you. So, you know,
Yeah. It'd be helpful for the patients out there to know that, like, I'm sure a lot of patients in a hospital are thinking, I don't like that one nurse. I prefer the other nurse. Well, guess what? The nurses kind of feel that way about you too, and it's not so bad. That's not a terrible thing. Yes, the nurses need to be professional about it, of course, and I trust that they would be. It's not about saying I don't like that person, but what I think the good thing about this is that the professionals on staff are giving consideration to matching patients to the person who's right for
hmm
them. And I think as if you're a patient out there listening, you might like to know that people are thinking about that, like who's a
right,
good match for you, and that the staff wants you to have a team member who's a good match for you. And
right.
you might have met a nurse who you didn't vibe with, but guess what? There's going to be other nurses.
Yep. Yep. Totally.
Yeah. Okay, so let's imagine, Andrea, a friend of yours who does not work in this field, calls you up and says, I'm really worried about my sister, my brother, my husband, my child. I think maybe they need to go to the psych ER. And they ask you, like, what the hell happens there?
Mhm.
Can you walk us through, like, what even happens if you take a loved one there?
Well, it's really, gosh, like anytime you go into the emergency department, you don't know how long of a wait period you have and what you're walking into, right? But when any psychiatric patients come in for a psychiatric evaluation, like they do with medical folks, they triage, what is going to need to be seen first or, more urgently. So those who come in and there's concern for safety in the sense of somebody says they're suicidal, something along that line, they're going to be moved along a little faster because they don't once that somebody says that, you don't want them out of your sight.
Yeah.
Um, for safety reasons, obviously. So, I mean, I can describe my work environment in the usual flow, which tends to be, from what I understand, pretty much this, not, I mean, yeah, pretty much the same idea overall, where you go. But so people come in, they go through the triage part that everybody goes through in terms of, medical or psych. Once it's determined that they need to have the psychiatric area or evaluation, um, sort of pathway, I guess you could say, they bring the patient to us. We are in the emergency department, but we're kind of tucked away in a little back area. It is locked, so people come in, and it's like a big room, a huge room. And we have several, the Jerry chair things that you can stretch out or like lay flat when you go visit somebody in the hospital, and it's that big chair that's all awkward looking and can recline and put your feet up. We have 10 of those. So it sounds kind of crazy the way the setup is, but it's all in one big room, so we can all see all the patients at the same time, which is obviously a safety issue. There's like these little walls between each chair, so you have somewhat of privacy from the other patients, but not really, because again, it's a safety thing.
Yeah.
Um, but basically, you come in, we have you go into a room with one of the staff members, and there's two security officers, and we do a search. Again, safety reasons, obviously. Um, you have to change out of your clothing into a hospital gown. Um, your stuff is inventoried, your stuff is searched. Uh, you're not allowed to have your cell phones. You're not allowed to have any of your regular clothing, at least during the evaluation process, until we get you transferred somewhere. And then we do routine blood work. You come on out with us in the big room. We do routine blood work, make sure that's all okay. Um, we check an alcohol level. We need a urine drug screen just to, again, see if there's anything in your system. Um, and I say that with the addition that we as nurses, we do not care what's in your urine screen. We really don't. We're not the
Yeah.
police. And, we're not going to be calling anybody saying, hey, this person has cocaine in their system. We don't care. We just need to know for clinical purposes. So, um, yeah. And then after that, you meet with one of our social workers. You go in a room, have a little privacy. You go over your history, your story. The way it works in our hospital is the social workers do the heavy lifting. They're the ones who do the evaluation. Um, then they will speak with the psychiatrist. We don't usually have a psychiatrist physically there, and then they determine what the best course of action would be.
Yeah.
So, whatever the disposition is, coming into the hospital or not, um, and then once they make that determination, then they speak with the emergency room attending doctor who kind of signs off on the plan, and then we go into the process of trying to find people a bed. So that's sort of the flow, I guess.
Yeah, I think that was really helpful. I think you've already clarified a bunch of things people probably would have wondered about. One thing I think people would have wondered about, but I think you've answered it, is they might have wondered, am I supposed to be like doing a Google search for psych emergency room? And I think you've already clarified. You just go to the emergency room and then they will triage accordingly where you need to be from there. Is that right?
Yeah, pretty much. Not all emergency departments have a locked psychiatric area. Any emergency department can handle a psychiatric evaluation. It's just how their setup is. Sometimes you go into an emergency department and you're by yourself in your little booth or cubby area, whatever you want to call it, and you may have a sitter, which is somebody that would be literally sitting there with you, a staff member, just to be able to be close by, keep an eye on you, make sure nothing's going wrong. So, some emergency rooms do it that way. Um, a lot of emergency rooms have like sort of taken on the idea of a psychiatric emergency service area. So I think as hospitals have upgraded and done new designs and blah blah blah, a lot of them have been moving towards that trend.
Yeah. And then it sounds like this is a space where people go to find immediate safety
Yeah,
while it is determined what would be more helpful for them, you know, I don't even want to say in the long run because I think the next step might not even be something that's long term. The
right.
next step might be something that's for like a week. Like, so I'm going to make up some numbers here. A person might be in a psych emergency room for like a day, and then they might go somewhere else for like a week. So we're still not talking about long term. But what would be that next step? Is it usually inpatient care? Is it sometimes outpatient care?
It can literally be anything. Um, so I'm speaking in terms of the state of Maryland that I'm familiar with. So every state has its own laws and, how you can get like involuntarily brought in against your will for an evaluation. That does happen. So, but I can speak for the state of Maryland anyway, in the sense that once you come in through the process, uh, there's several dispositions that we look at. We can, if somebody agrees that they need a psychiatric hospitalization, then they would come in as a voluntary patient. So they're saying everybody's on the same page, basically. Okay, let's go. I need inpatient treatment. All right, cool. So that's disposition one. Um, and then for my hospital, we have a unit that is all voluntary. So if you say you want to come into the hospital and we have an open bed on our inpatient unit, that's the first track. Uh, if we don't have any beds, then we have to look at transferring you to another hospital. But um, so that's disposition one. And then we have involuntary. So basically, somebody does not want to come into the hospital, or they're so out of touch with reality that they can't make any decision about that anyway. So the determination is made by the psychiatric team, i.e., social work, psychiatrist, and you're brought into the hospital whether you want to be or not. Um, that doesn't always go over well, but for safety, either danger to self or others, or again, somebody is so out of touch with reality that they don't know what's going on, then someone can be brought in against their will. Um, so that's involuntary. But then we also do consults, I mean, not consults, we do referrals to like substance abuse treatments. We will do a straight discharge back home with resources. People come in from assisted livings, group homes, places like that. We'll discharge them back to that. Sometimes we determine that this is not psychiatric, it's actually medical. So they go medical. Um, it's really, really, we also have an inpatient substance abuse unit. So if you need inpatient treatment for substance abuse, we can do that too.
Yeah, so this is not like like an immediate it's not an immediate jump to you need to be hospitalized. And I think a lot of people would like to know that like they may have a loved one who's struggling in some way, but they don't really know what the loved one needs. Well, this could be a step to take to determine with a professional what might your loved one need. Like, do they
Right.
need to be inpatient? Could they maybe just get a therapist? Maybe that would be helpful. Is it maybe they are totally fine and everybody else is just worried about nothing? Or is it
Right.
medical? This is just a place to go to figure that out.
Right. Right. And I will say that if in the event that somebody is concerned one of the options if you're in the community. It's worth finding out if there is a community response team, like a crisis response, because that's also more and more common that you can actually have crisis people come out to your home or in the community to assess whether somebody even needs to come into the emergency department. Because once you start that process in the emergency department, it's not exactly fast. It takes several hours, and it's not always the most comfortable place to be, obviously. And so, once you start that process, you have to go through the process.
Yeah.
So if you can have somebody meet you in the community to assess things, that's always good too.
That is really good advice. Now, that doesn't exist everywhere,
Right.
but if it does exist, what a great resource to be able to say, you know what, I'm just worried about somebody, and the emergency room feels like a really big step. Maybe calling a crisis response team is a smaller step, just to bring somebody out in their environment where they're comfortable to come visit someone and just do like a check-in.
Yes. And which kind of leads me to the part that I was saying I have very mixed feelings on is if you're in the community or, it's your loved one or whoever, and you call 911. That's always an option. But I mean, I will be honest and say you don't necessarily know how that's going to turn out. Police aren't necessarily going to be the most effective in de-escalating the situation. They have different kind of training. So, and the last thing you want to think that you call 911 for help and things go right off the rails. And so, that's why a crisis response team is, if that's an option, if that's in your community, I would definitely utilize that.
That's great. That's good advice. Um, Let's imagine someone does make it to inpatient care. Now, this is where you and I met, which sounds funny to say. We met at an inpatient psychiatric
Yes, we
hospital,
did.
but we've both done that work. And one of the questions I get all the time is, "Hey, does it like the movies?" Now, it's always hard for me to answer. Maybe it's because I haven't seen that many movies about inpatient psychiatric care, but I don't know. I'm inclined to say no. I don't think it's really like the movies. I'll just say my experience working in an inpatient psychiatric facility with adolescent boys was at times it felt like camp, like we were playing basketball in the gym, and we were doing like recreational therapy, right? They were games, but they still helped people get in touch with their feelings and
Right.
their
Team
conflicts and
building
their
and all that.
yeah, yeah.
Mhm.
I mean, even team building may not sound like it's all that necessary when someone is having a psychiatric crisis, but it might help understand why there are challenges at home if you struggle with being on a team and your family is kind of like a team. So anyway, I felt that the work we were doing often seemed at times light and even at times kind of fun, like we were
Right.
laughing. It's not the total chaos that I have seen in movies. But what can you add to that?
I mean, to be honest, it's been so many years since I've done inpatient. It was with you,
Yeah.
basically. Um, so I know in terms of our voluntary unit, again, is it like the movies? I think there's always going to be those patients that are pretty stereotypical movie-like, um, but obviously that's sensationalized in a lot of senses. I think most of the time it's very chill.
Yeah.
It's like, yeah, you do groups. You have a therapist that'll be leading a group or, you know, whatever kind of group, whether it's talking groups or whether it's, various skills groups. So I think for the most part, it can be pretty chill. And it's like that in our part of the emergency room too. Um, the way the setup is with the big room, we have the big room and then we have the nurse's station. And so there's nowhere for any of us to go. So we're sitting at the nurse's station. The patients are sitting at their chairs. So if you were looking from the outside, you'd be like, what are they even doing? Like, what are they doing? All they do is sit there. Well, yeah, ideally, because, that means it's chill, right? That means it's calm, nothing crazy is going on. Um, but I think one of the keys or clues to how successful a unit is that the reason why it's chill is because you've been proactive. You've addressed things before they become a blowout crisis. Whether that's talking with somebody, removing somebody from the environment, medicating, or offering medication, whatever. If you see a chill psychiatric area, that's good. That means people know what they're doing. So, it can look boring, in fact. Yeah, and that's a good thing. Uh,
Yeah. Yeah. I think you're making a good point that the calm nature of that space speaks to how proactive you've been. You're noticing signs that somebody's getting agitated and you're intervening before it turns into a great big thing.
Absolutely. And that's where I think the art comes in,
Yeah.
the art of doing it.
Okay, so I think where we're going next here is just, are there any other tips or thoughts you have if somebody is concerned that they have a loved one with maybe some kind of severe mental illness? Um, anything that you think they should know? Like, you've already given some really great ideas about a crisis response team, what they could expect if they do go to the psych ER. What else do you think may be just helpful to know, or even things to avoid, things not to do if you think your loved one has some severe mental health concerns?
Well, again, it depends on the state, but and what they are called. But in Maryland, there is something called an emergency petition. So an emergency petition can be initiated by um a doctor, nurse practitioner, therapist, someone along that line. Could also be initiated by the police. It can be that can be it can be hit or miss in terms of how helpful that can be. But it is an option. So like say the police respond and someone is doing something that is questionable about the safety. The police can say, okay, come on, we need to go to the emergency department. Or you as a family member who whatever, you may say, come on, let's go to the emergency department. Let's go get you checked out, or let's go see, have you talked to somebody, blah, blah, blah. If the person does not agree, there can be an emergency petition filed. So that can be in the moment where police will write up a paper. It's a legal document. It allows the police to bring you to the hospital, whether you want to or not. So again, that's scary in a lot of senses, but it could save your life, um, or somebody else's life. So if there's ever a situation where you're acutely concerned in the moment, this is going really bad, this is really unsafe, the person is trying to kill themselves, the person is actively saying they're going to kill somebody, the person is so psychotic that, they're completely paranoid and they're locked up in their room with guns or something like that, that's where 911 would be good along with crisis response, ideally. Um, but the police can do the emergency petitioning.
Mhm.
So um, that's one thing to keep in mind. But the part two of that, or the other part of that, is that if you are concerned about somebody, like a loved one, or even, a neighbor, somebody in your life that you're concerned about, you can go to a courthouse before a judge and say you want an emergency petition.
Mm.
So if, say it's my son and I'm concerned and I'm seeing this pattern of behavior that I'm saying like this person needs to be evaluated or my son needs to be evaluated, needs some psychiatric treatment, I could go to a courthouse, I could go before a judge and I could say, I want my kid to get treatment or get evaluated for treatment. The judge can sign off on that and say, okay, here you go. And then the police would go pick the person up and bring them to the emergency department. Again, that can be both good or bad.
One thing I was thinking is, I know somebody whose son has a lot of behavior problems, and the idea has been floated that, like, if things don't get better, they might look at hospitalization, like, next time there's a big explosion or next time he's really, aggressive. And my friend who heard this about his own son came to me just outraged and said, "Can you believe they want to hospitalize my kid? It's not his fault that he acts this way. It's not his fault that he has these problems." And I said, nobody, nobody said it's his fault.
Right,
I think there's a misconception that going to the hospital is like going to prison. Like
right,
going to the hospital is a punishment. And I found myself explaining to him that the hospital is care for your child.
right,
That is treatment. That is help for him so that he doesn't have to suffer. That he may be acting this way because he is suffering. And if someone out there has an idea about how to end his suffering and make things
right.
better, then why wouldn't we take advantage of a hospital to do that? So I guess I just wanted the audience to hear that a hospital is not a punishment, even though the door is locked and that feels like
Yep,
jail. Um, it's different than jail. There are way worse places your family or your loved ones could be than a hospital.
right. That's completely, totally accurate. Um, Again, and a lot of times, people that come in, especially if they're brought in against their will, um, they're not happy about it. And we have family members and other people that are not happy about it. But, you know, I worked in substance abuse treatment for years, and I think of this in terms of substance abuse, but I also think of this in terms of psych. You I used to say, you can't help a dead addict. So even if you have to keep trying over and over and over for treatment, if they're alive, you're already got to win. So it's the same with psych. Um, it may not always be the best, most fun experience, but if it's keeping somebody alive or if it's keeping somebody from being hurt, um, then that's a win. Um, I think it's important for, or I think this is one of the benefits, at least if your staff are aware of this, um, it's worth recognizing that coming into the hospital, coming into the emergency department can be a very traumatic experience. And the only reason why I keep saying going back to that is because there is stuff that's scary. There is stuff, you do see some really sick patients. You do have some patients that are extremely, they're extremely labile, extremely explosive. There's ones that are violent. But if you are in an environment that you have skilled staff and security, then we roll with it. We're used to it. We know how to handle it.
Yeah.
But I think what's important is for us to remember that those that are there for treatment or evaluation, they're not used to that.
Mhm.
And what may be routine to us can be incredibly scary to somebody that is sitting there. So I think it's worth knowing that in the sense that um, it could be traumatizing or re-traumatizing to people that have never been through this experience. And that's where you're going to reach out to those staff that you feel safe with.
Yeah.
The goal is to get you safely onto the next level, whatever that level is.
Yeah. I think the summary here is that it can be chaotic, but it isn't all the time. And I think
Right.
that's where I was going when I said, it's not like the movies where it's just like objects flying around and people, tossing
Right.
furniture constantly. I mean, yeah, I have seen a table go across a room working
Sure.
in an inpatient hospital. I have seen it, but I still think about those days because they were not every day.
Correct.
They were occasional. So the reality is it can be like that, and it is not always like that.
Exactly.
Yeah, thanks for that. This has been great. I want to thank you for sharing this experience because I'm telling you, there are people out there who are worried about their loved ones, and half of the worry is the mystery of it all. Like, I don't
Right.
even know what happens if I call 911. I don't even know what happens if we go to the emergency room. And I think by listening to this, you've removed a little bit of the mystery. And I'm not saying that makes it easy to do any of these things, but I think that you've made it a little easier. And
Hmm.
so I'm really grateful. Thanks for doing this.
Of course. I appreciate you inviting me to do so.
Take me in your arms. I don't want to miss a day without you. Let's stay young forever. There is nothing we can't do. And nothing can break us apart when we're together. Facing the sky, we know that we can fly on the wings of love. And we can climb on every mountain top. I never knew eternity was real till I met you. Since that day, I live in a dream.